All right, so we are here with Dr. Jennifer Mercier. I followed her work after I found out about her technique in a few years ago when I was at another visceral manipulation course, and some of the other students in the course were talking about her work, and I just wanted to give that brief intro, which she's going to introduce herself, and she has lots of accolades and lots of different projects going on. So here is Dr. Jennifer.
Good morning, Kate. Thank you for having me. Yeah, as you said, this work is a visceral application, and I've been working on it now for almost 25 years. I started teaching it in 2006 and have had nothing but great results since then. From the people that I train to my own practice. I've written a couple of research abstracts and had them published domestically and abroad. And it never ceases to amaze who reads those and how that information has helped so many. And from the professional perspective of having those come to me and ask me, hey, how did you create this? How did you get this all in motion? And it basically was born of a need for my own stage 4 endometriosis.
Oh, wow.
Yeah, I mean, there were no good options to treat it other than Lupron suppression therapy or oral contraceptives. And I never did Lupron. I had 3 surgeries to clean up the disease. And I did try oral contraceptives back when I was in college because I had to do something.
Yeah.
And I didn't really know too much back then. So I gained a lot of weight. I had wretched headaches from oral contraceptive pills, and it just wasn't good for me. And I didn't feel well. So I started building this out of a need for my own self. And undergrad, I was pre-med. I worked for the Center for Human Reproduction, which was a large reproductive endocrinology and fertility clinic here in Illinois. I was trained as a clinician. So I was 19 and 20 years old, learning how to do an intrauterine insemination, semen analysis, pelvic ultrasounds, endometrial biopsies, pap smears. I went into hysterosalpingograms and egg retrievals, embryo transfers. I monitored those cycles from start to finish. So it's a language I speak. Nothing much has changed today in reproductive medicine. It's all pretty much the same. Now we have more drugs that are less potent as the ones we used to use. So, and the numbers are about the same too. They're not very good. Let's put it that way. They're just not very good. You can access the data yourself at SART, S-A-R-T, the Society of Assisted Reproductive Technology.org yourself. There's preliminary data there from the last 2 years. Data is usually a couple of years behind, but you can go there and see the stats yourself and make a decision as to if you think IVF would be good for you. So I'm a researcher. I'm an ND PhD. I'm also a midwife. I spend a lot of time researching, and so information I bring to you is truthful information. And I just want women to have the ability to make good, sensible choices for their care. And if it's IVF, well, then that's their choice. I tend to, create a better environment, certainly in a woman's body, help to create a better environment prior to going to IVF, because it's such a treacherous journey through that kind of cycle or multiple cycles. But it's ultimately a woman's choice to do what she wants to do.
I was surprised by the documentary that you produced with how new. I guess I had never thought about how long has the fertility field been around. So that was kind of surprising to me, how new it is. And then I had no idea what the actual stats were on how successful it is. So that was eye opener because, so many of my patients and friends and everything spend a ton of money, and that is not a great percentage of what is successful.
Right. Right. I mean, 22 to 23% pregnancy rate and a 19% live birth rate isn't great for all of the things that you put your body through and for all of the money that you spend on one cycle. I mean, and you could potentially do multiple cycles and put yourself into serious debt. And I've seen women refinance their home, sell their car, sell their wedding band, just to have the revenue to do more IVF, just to fail over and over again. It's heart-wrenching, honestly. And what they're putting their body through, we don't know altogether long-term what an IVF regime can do to a woman's health in the immediate time, but also in the longer term. And it's actually a bit frightening to me because we're literally taking a cycle up so high of estradiol to make multiple follicles, and then we're dropping it down after the retrieval, and then we're doing it again and again, because now these clinics are urging women to bank their embryos. So to go in, do an IVF, make the embryos, bank them, so freeze them, then do another retrieval cycle, make more embryos, freeze them, and continue that until they have a decent amount of embryos frozen, and then prepare the woman for an embryo transfer. And then they thaw them 2 by 2 to see if they're going to, if these blastocyst embryos are going to withstand the thaw, and then they transfer them. But here's the other moral and ethical dilemma is, let's say that a woman gets pregnant on her first transfer, 2 embryos transferred, both of them split, now you have quadruplets, and you have 10 embryos frozen. Maybe 4 kids is, more than you'd ever thought, and you're good. You don't need any more babies. What do you do with those embryos? Do you donate them to stem cell research or some sort of scientific research? Do you adopt them out to other people? Do you donate them, knowing full well that your full biologic and genetic material is, your children are somewhere out there with another family? So it's really, there are a lot of components and working parts of IVF that need to be considered. And I am so thankful that we have it, because there are some women that really, really need it. I mean, had a woman, I've had several scenarios, but this one comes to mind first and foremost. She was born with a form of spina bifida that allowed for closure at the base of the spine, but she had a uterus that was unicornuate, so just one horn, but both of her tubes didn't communicate with the uterus. So if the tubes don't communicate, then IVF would be technically the only way for her to get pregnant. So there are cases that which we need to reserve IVF for, and then there are other situations where we're pushing women through IVF like right out of the gate. This is like not first line stuff, guys. This is big. This is huge that we rush right into IVF as the first line of trying to help someone get pregnant, but we're not helping, we're forcing. Now we're in a place of force.
Yeah.
And is it good to force our body to do anything is the question. You know what I mean?
Yeah, for sure.
Yeah.
Actually, I've seen that in my practice, that it's happened with some, and it seems like it's such a gray area. And the one patient I'm thinking of, they were with a fertility doctor. That doctor suggested right out of the gate, like you're saying, IVF, and then the first round failed. He retired. They moved to another doctor within the same practice, and they looked at her chart and were like, oh, this is weird. You should just do a round of Clomid. And she got pregnant right away. So yeah, it's such a gray area, and it's like you think that it's this cut and dry. This is what we do. This is what you have it going on. But you're going to get, just like with surgery, you're going to get a different opinion depending on what doctor you see. So
Yeah, it's true. It's true. And it's interesting to your point, your client or your patient that got pregnant with Clomid. There's also caveats, of course, with Clomid, because what we're really using Clomid and Femera or letrozole for is ovulation induction. And there is something much more gentle that we can use, which would be ultrasound monitoring of the follicular growth. Also LH testing at home, and then an induction of ovulation with an HCG trigger shot, which is so much less invasive than using these estradiol inhibiting drugs. Clomid causes poor fertile mucus. It literally causes a very acidic environment in the vagina. And then almost always with Clomid, we should be coupling, not almost always, we should be coupling a Clomid cycle with an IUI, bypassing that vaginal environment altogether because it's inhospitable to sperm. I mean, we have literally taken women down to bare bones levels of estrogen with Clomid and Femera cycles. And so right there, and both of these drugs, like a Femera is a drug that's an anti-neoplastic. So it's an anti-cancer, breast cancer drug. And we're using it off label for ovulation induction because we're tricking the pituitary gland into making more FSH while suppressing estradiol production. Estradiol it thickens up the endometrial lining. It creates a good, healthy environment for the growing egg in the follicle. And if we don't have enough estradiol at the beginning of a pregnancy, the baby will, or the embryo, chances are will implant, but not go any further than 6 weeks because we are in deficit of estradiol, which is responsible for growing the vital organs of the embryo, the heart, the brain, and the spinal cord. And so if you start out at a deficit using a drug that's contraindicated with pregnancy, it just, there's too much, it's too much like playing with puppets. You know, like, let's see if I fine tune this one or this one to make this work. It's just a lot of messing around. And so that's why I really like that ovulation induction or trigger, I should say, with HCG. I mean, that's benign enough. We make HCG on our own. Using an HCG product is probably the lesser of the two evils, truly.
Yeah. Do you want to explain how your technique helps with better blood flow and what that means for?
Certainly. Yeah, Mercier therapy is a deep pelvic organ visceral manipulation. It helps to enable better movement, releasing restrictions in organs in the reproductive organ system, and it also increases blood flow. And so blood flow equals life. I mean, I always use this example, and you'll see it in my film. If you cross your legs, your foot falls asleep, your foot is completely not like it's numb. You can't feel it. You can't stand up and walk around and bear weight on it, or you'd fall. So what do? We uncross our legs, we gently tap out our foot, and then the pins and needles come. That restoration of blood flow back to the limb can be kind of a strange sensation and almost a little bit painful. And so that's the same as what happens in the pelvis when it's either a surgical pelvis and there's scar tissue there, kind of locking everything down and locking it into place, or if there is a restriction of mobility in the uterus because of a fall or an accident. I get in there, we work very, very deep, and I manipulate the organs to restore their movement, which brings the blood flow back. So it can be a tender process, but it's so great because as we keep working, and it's 6 sessions, 6 one-hour sessions, or if a woman is going to fly in to see me or drive in to see me for the 4-day condensed shared journey for fertility program, we're working at least 6 hours. At least 6 hours is what I arrived at when I did my study. So we're doing the work in the 4-hour or 4-day protocol. It's 90 minutes a day for each day. Consecutively, but it can cause some tenderness, and you will be aware of the space because most women that are trying to get pregnant may have a memory or something in there of that area between the navel and the pubic bone that isn't quite settling, whether it be an unwanted sexual trauma or experience,
Mhm.
or painful menstrual cycles, or a pregnancy loss, or an abortion,
Mhm.
or a stillborn, or whatever the case may be. It's something that's unpleasant in the memory of that space. I go right back in there and I flip the light switch on, and it starts this whole cascade of events, whether it be, you know, connecting up the pituitary and the whole pelvis again, to hear the calling of, you know, from the pituitary gland, hey girls, make some estrogen, and they boom turn on, and here we go. Better lubrication, better ovulatory cycles. It's just really simple. Truly, it's simple work.
Mhm.
And that's what the body needs. The body needs like a gentle nudge, not pounding a thumbtack with a sledgehammer.
Mhm.
That never works well.
For the patients that come in from all over and you do that condensed, do they have to come back, or do you give them stuff they can do on their own, or?
Once the work is done, the work is done. They do not have to come back. They're always welcome to come back. But no, once the work is done, that's it. Now, if I'm working with someone who is going to have a surgery in the future, I would say let's wait until after the surgery to work on you,
Mhm.
because obviously the body's protective mechanism is to make scar tissue, and that will be in abundance again. So let's just wait until after the surgery. Now, if the surgery is going to be a big surgery and it follows all these little surgeries and we're going in to do a final cleanup,
Mhm.
it is a good idea to do the work prior to the surgery to make the surgery a lot easier on the surgeon. The
Well,
less dense scar tissue that they have to dissect through, the less time the patient is under anesthesia and opened and what have you. So it can be used in both ways, pre and post. It just depends on the case.
mhm. Nice. And then how long do you wait after surgery?
8 weeks.
Nice.
6 weeks in some cases, 8 weeks in most cases.
Mm-hmm. Awesome. Now,
Yeah.
with the, you know, like I have a lot of patients that have endometriosis, PCOS, that kind of thing. And I've I've read in your stuff that your therapy also helps with those conditions as well.
Yeah, I see a lot of endo, I see a lot of PCO and PCOS. Again, just helping to soften and break up adhesion tissue in the pelvis it's miraculous. I mean, I have stage 4 endometriosis, and
Mhm.
my own work helped me to have 2 healthy babies.
Mhm.
Had I not had my own work, I truly believe that I wouldn't have babies. I mean, I was told by the 3rd surgeon who operated on me that, and this guy's a friend of mine, and he knows better than to push his IVF on me, and he did. He's like, no, really, everything does not look good in there. You're going to have IVF. And I was like, all right, I'll let you know when I'm pregnant. Thank you, though. And so I did just that. I showed up in his office. I'm like, all right, flip on that ultrasound, brother. Let's see what's in there. And there we go. I was pregnant. And it was after I had a group of my students work on me.
Oh, okay.
So I really believe in my work. And you know what? If someone needs a little medical intervention, I'm happy to liaison them through that, again, because I speak that language.
Okay.
And I teach my students to speak that language too.
Mhm.
If there's a more advanced case, I recommend they come to me to see me, unless I've got somebody in their area, a geographical area, to, you know, that is just as well versed as I am. But you also asked about PCO and PCOS. I see this all the time, and I do the work, but then I also accompany with a bioidentical hormone and supplemental protocol. I do my very best to help them understand dietary changes
Mhm.
because of the precursor of diabetes, for PCO, PCOS,
Mhm.
mostly PCOS. Sometimes I get diabetic women that have PCO already,
Mhm.
and they don't have very good control of their blood sugars. So we talk about that. Yeah, it's an all-encompassing program. It's like a holistic reproductive endocrinology and fertility program, without stepping on, the toes of the medical industry. And I don't do what they do and they don't do what I do. So it's,
nice.
It works well.
I was looking at, you have so if you're a provider, you have 3 different courses that you offer to healthcare professionals. Who do you usually get attending your courses?
Physical therapists, massage therapists, chiropractors, napropaths, naturopaths, physician assistants, nurse practitioners, physicians. I do have a few unlicensed providers like doulas, childbirth educators. Oh, I do get midwives. I had one Pilates instructor. I don't think anybody is off limits with this work if they either have a license to put their hands on people or are just wanting to really help the women in their community. This is not a licensed application. I mean, you don't have to recommend bioidentical hormones or supplements. I already have that all written out for them. If they want to recommend anything to their clients, they can buy it over the counter. So there's no licensure, scope of practice issues here. And Mercier therapy is not massage, it's body work. It's an old traditional osteopathic type of manipulation. So there's a myriad of different people that come and train with me, and I love it.
Now, let's see, I saw the one course that you have is just visceral. So do you gear that more towards also some gastrointestinal stuff as well?
Yeah, the visceral course is all GI.
Okay.
It's all GI. And as of 2022, I will be combining the 3-day original course with the fertility certificate course. So there won't be 2 courses any longer. It will just be 1 course.
Okay.
And I mean, it's necessary for people that want to train with me to have both courses, because I tell them, you cannot go out and use this work for women with fertility challenges if you don't have the fertility certificate. And so what's the point then, really? I mean, you want to be full scope. If you just want to treat women or take care of women that have pelvic pain, well, that's one thing. But if the consumer is looking for someone who can help them with fertility and you don't have that course under your belt, then you're not allowed to use Mercier therapy. So I want to make it so everybody has the full circle of training, and that will happen January 1st, 2022.
Awesome. That is something on my list for, I did a lot of continuing ed in the past pre-COVID, and now it was all online essentially for a long time. Yeah. It would be nice to do an in-person course again.
Yeah, no, I hear you. And all of my classes will always have to be in person. I mean, because we have to touch people.
Yeah.
So, yeah.
How do you feel the connection? Like, I do a lot of pelvic floor style stuff with like DNS and that kind of thing. How do you feel that this pairs well with that kind of work as well?
Absolutely. Yeah. I think that chiropractic and any other physical modality would be lovely against, what we do in Mercier therapy. Here's the thing though, to keep the work pure, and if I ever called for data, and I tell my students this all the time, you would have to have cases only that you used Mercier therapy for, if that was the study criteria. So I say keep them separated, unless you've got somebody that has pelvic floor issues and you need to incorporate, more specific pelvic work or pelvic floor work with Mercier therapy, then you could certainly do that. Yeah.
Nice. How do you find your therapy works with things like prolapses and stuff?
Oh yeah, really nice. Because we're working directly on the ligamentous system in the pelvis, and we're pulling the uterus up into the pelvis, retraining the ligaments in essence. Now, sometimes I do have women that have severe prolapse, and I will ask their gynecologist to fit them for a pessary device while I'm doing the work. So in combination, so that we can really retrain those ligaments. I mean, I've had some pretty severe prolapse, like women's cervix hanging out of their vagina. And those are already slated to be surgical cases from an obstetric and gynecologic perspective. But sometimes we can help and sometimes we are not able to help, but it's certainly worth a try before going in and having uterine suspension surgery or having the uterus taken out altogether. Yeah.
When they have a uterine suspension surgery, do you go in and work on post-surgery from that?
No, I don't really do much with that. I don't want to disrupt. I don't want to disrupt. And, you know, most gynecologists aren't really doing that too much anymore. It's kind of the older ones that are accustomed to that. But yeah, I don't do that. I don't want to interrupt. Similar with a bladder sling. A lot of docs aren't doing bladder slings anymore either, but I will go ahead and work, you know, if it's an older case and someone's complaining of issues again or pain. I don't know if you're familiar with the documentary called The Bleeding Edge on Netflix, but they go over what surgical mesh does to organs over time. And I would really recommend that you watch it because some of this mesh is what they were using to build these slings, and it would grow into the bladder and not be able to be removed in its entirety. So take a look at The Bleeding Edge. And it goes into the eSure device, which was pulled off the market. I think January 1st, 2018 is when it was pulled off the market. But that was the little coils that were being put up into the uterine horns to scar them over. And it was a permanent birth control methodology. But yeah, it's been pulled off the market, which is great. Because those little coils, and if you've ever opened up like a pen and there's that little spring inside, that's what they looked like, those springs. And they were finding that those were breaking down inside of the tubes and migrating throughout the pelvis, causing terrible pain and all kinds of different scenarios that were perforating other organs. And so it's a good one to watch.
Makes you definitely rethink, you know, like, oh yeah, this great thing that's gonna fix you, but maybe, you know, and who can foresee 10, 15 years down the road if it just came out what it might be able to do to you later.
Right. Right. Yeah.
Well, thank you so much. So I'm located in Pennsylvania. I know Mercier therapist in Cleveland, Dr. Candace Gasecki.
Yeah, Candace.
I'm not sure if she's the closest one to our western corner of PA or not, but
there's two in Pennsylvania now as of April, Leanne Skinner and Sandra Eusteris. And they're both PTs and they're both wonderful. And I'm happy to give that information to you. Candace is always great too. So whomever they're, you know, closer to can see any of those ladies.
Yeah, and I hope to take your course someday because I have been eyeing it up for years. So now that we're traveling a bit more, I will. And I like the idea that you said, you know, because taking time out of a busy practice to go do is difficult. But I like the idea of pairing the two because then it's, you know,
it makes it a little more palatable to take 4 days from your practice as opposed to a full week, and just condense it up. And you know, anyone who takes my courses always has my support via a Facebook practitioner group or of course email. I'm always willing to help with different cases because this is, again, it's another language, and if you don't speak it even just a little bit, it's going to be a challenge. But we need more people out there practicing Mercier therapy. There's definitely enough women to work with.
Yeah, and I will put the link for your websites and your documentary that is so informative and really a great watch. And also, you said you had a book coming out.
Yeah.
Or when is your book coming out?
Well, I'm just waiting to do one last meeting with my publisher, and then hopefully by October. But the book is called Conceive, And it's very eye-opening to what's going on in reproductive medicine, but also on, what we do, and some stories are shared of couples that we've worked with. And I'm actually really proud of my book.
Yeah, and I think I heard this in your documentary, but I just wanted you to point out your success rate because I was floored with it on the documentary.
Yeah, so in 2012, when I published my abstract, it was 83%, and it still hovers around the same.
Yeah,
And these are women that have failed medical attempts, and they come in, they get pregnant, and they're just absolutely shocked. Well, I've done 6 IVFs, and now I'm pregnant.
Well, it was great talking with you. I'm so glad we got to do this, and thank you for your time.
My pleasure. Yeah, it's so nice to talk to you too, Kate. Thanks for having me on.
Yep. All right. Have a good one.
You too.